It's my pleasure to introduce the next speaker, a longtime friend, Dr. Elizabeth Braunlin, who's a professor of pediatric cardiology at the University of Minnesota and director of the Pediatric Cardiology Fellowship Program. She's been a major force in terms of MPS and help us understand the challenges of the cardiac disease. Liz, it's my pleasure to hear your presentation.
Oh, thank you, Dr. Munzer. And it's a real honor to be asked to talk at the Munzer Center. The Munzer Center is certainly tangible evidence of your lifelong devotion to studying MPS, and it's a beautiful thing. Today, I'd like to talk about cardiac findings in MPS. And as you probably know, being from Minnesota, the main patient population that we have in Minnesota is MPS 1, although I do see many patients who have come for uh, um, enzyme replacement therapy with the other types of MPS. So I have no conflicts of interest. Nobody wants to pay me to do anything, I guess. Um, My objectives today would be to describe to you the best method to establish the cardiac features of MPS and to define the three major cardiac findings in the MPS disorders, to describe age-related differences in the cardiac findings, and then to recognize the cardiac response to current MPS therapies. So we've talked about the diagnostic odyssey already today for MPS patients that is still going on for those who don't have MPS 1 or 2, and even less so for MPS 2, since not many states are doing newborn screening for MPS 2 yet. So it's important to know how you can diagnose MPS in a young infant. Well, the cardiac findings in MPS are best determined by cardiac echo. Physical exam is usually pretty unrewarding, especially in young children. And when you go to the cardiac features of MPS, it's very uncommon to hear murmurs in young children. Partly it's difficult to hear them because they're difficult to examine. You have airway sounds, and even if there is the presence of valve regurgitation, it's uncommon to hear valve regurgitation murmurs unless the regurgitation is moderate or severe. Chest X-ray and EKG, when you're talking about the cardiac features of MPS, don't demonstrate cardiac anatomy or cardiac function. Chest CT and cardiac MRI are also things that you can use to determine the cardiac features of MPS, but they're very expensive and they require sedation. So cardiac echo usually doesn't require sedation, and it's very good at defining cardiac anatomy and function. It's something that can be done repeatedly over the child's life. The one thing that cardiac echo doesn't tell us is whether there is coronary artery disease in MPS. And you can see cardiac coronary artery disease in many forms of MPS, where there is myointimal proliferation, as shown in the blue inner part of the circle there in a young infant with MPS 1. So cardiac echo can't tell you that. And as a consequence, we always treat all of the MPS patients who come to us as if they all had some involvement of the coronary arteries. Cardiac finding number one for MPS is that the anatomy is normal and systolic cardiac function is usually normal. That is to say, there's two atria, two ventricles, four cardiac valves. There's normal cardiac function in patients with MPS with a proviso, which I'll get to in a minute. So we determine cardiac function with cardiac ultrasound by measuring an ejection fraction. There are two types of ejection fraction that you can see on an echo report. One is called a measured ejection fraction, which I'm showing you here, where the left ventricle is actually traced in diastole on the left and in systole on the right. And the ejection fraction is simply the diastolic area minus the systolic area over the diastolic area expressed as a percent. Usually people think that a normal ejection fraction is greater than 50%. Cardiac function can, however, be decreased in young infants, especially in the MPS 1 population. You can see decreased cardiac function in 25% of patients that you see who are under 6 months of age. This becomes important, and I'll tell you why later on when we talk about newborn screening for MPS. So cardiac findings number 2 and 3 are that the cardiac valves are involved in MPS, and the aortic root can be abnormal in MPS. On the left, you see a normal cardiac valve on the upper left-hand panel, and then you see a thickened MPS mitral valve. In the bottom left right-hand panel, you can see a short axis view of the aortic valve. You can see how difficult it is to see the leaflets of the aortic valve where the arrow is pointing. In contrast, on the right-hand lower panel, where there is an MPS aortic valve, and see how easy it is to see the thickened aortic valve leaflets on cardiac echo. So thickened valve leaflets can be seen on cardiac echo fairly easily. It's not so much the thickening as the function of the cardiac valve because they can leak and they can become stenotic. Notably, something that we've realized within the last 8 or 10 years is that the aortic root in MPS patients can be dilated. And on the left-hand panel, you see an 11-year-old with aortic sinuses. That's the measurement that we use for the aortic root being 2.2 centimeters. On the right-hand panel, you see a 2-year-old whose aortic root is actually even bigger than that and is 2.3 centimeters. So how do you deal with that? What can you say about that? Well, we use a z-score, and you'll oftentimes see a z-score measured with these aortic root dimensions. And so a z-score compares the patient's measured value to the average value for their body surface area. So a z-score of 0 would be an average z-score, and a z-score greater than 2 would be 2 standard deviations greater than normal. So if you did a z-score for the 11-year-old, his z-score would be slightly elevated. It would be 2.2. But now if you did a z-score for the 2-year-old, you could see just how dramatically enlarged the aortic root would be. So z-scores are a way of comparing a child over time to see whether the z-score increases or stays the same, or to compare two different children. So as we've talked before, the MPS phenotype develops over time. And this is a nice picture that Paul Harmatz published many years ago showing how the physical features of a child look fairly normal in infancy, but over time as they become adults, they develop the classic coarsened facial features that is seen in MPS 2. The same thing happens with the heart. Cardiac findings increase over time with MPS. So, what are those findings? We're seeing a lot of infants with MPS now identified by newborn screen, and under 6 months of age, they form a particular pattern. The cardiac systolic function can be decreased. This is an important thing to know because they're going to undergo anesthesia, get line placement for enzyme replacement. or they're going to undergo anesthesia for LPs. And it's important to know that they can withstand the anesthetic that they're going to get. So in MPS 1, about 25 to 30% of infants under 6 months of age will have decreased function below 50%. There are also case reports from the old literature of patients with MPS 6 that have had decreased cardiac systolic function. I have not seen any, I could not find any patients who are under 6 months of age with MPS 2 or 4 that had decreased systolic function. But there's not a lot of literature out there about infants under 6 months of age with those types of MPS. Valve thickening and regurgitation can already be present in children under 6 months of age. It can be mild, and the regurgitation can be mild, but you can see it, and you see it in MPS 1, 2, 3, and 4. Valve stenosis, on the other hand, is a late finding, and I have yet to see valve stenosis in an MPS patient under 6 months of age. Aortic root dilation can be present and can include the aortic annulus even in young infants, especially in MPS 1 that I see a lot of, can have aortic root dilation greater than 2 in infants with MPS 1. So if you made a little box diagram, the important thing to remember is that cardiac function can be decreased. And on the right, you see the measurement of an ejection fraction in a normal patient. Left is the diastolic measurement, and right is the systolic measurement. And the ejection fraction is 60%. Whereas in an infant, you see that the left ventricle can be dilated, and on the left, the measurement of diastolic area, and on the right, there's not much change with the systolic area. And so that patient actually had an ejection fraction that was well under 50% and needed to be treated. You can see, here's a picture of a color Doppler signal showing left ventricle, and the blue jet is a small jet of mitral regurgitation that was seen in a 3-week-old infant with MPS 1. So it can happen, but it's very mild. And then you can see the aortic root dilation that we talked about earlier in MPS 1. Aortic root dilation is kind of a background theme for MPSs. And so in Taiwan, where they have been doing newborn screening for almost 10 years now in many different types of MPS, they've actually recently published a paper, and the arrow showing the graph at the bottom shows in orange the amount of cardiac abnormalities that they see in newborns, valve abnormalities, versus the MPS type. And you can see that 5% of MPS 2 patients will have some sort of valve abnormality, up to 13% in the MPS 1 patients. And the blue columns represent patent foramen ovale, or ASD. And as we all know, as cardiologists, patent foramen ovale is a normal finding in infant echo up to about a year of age. And even after a year of age, it can occur in about a third of us. So they just noted that as an interesting thing for the newborns with these various types of MPS. Cardiac findings in older infants with MPS, they most often have a normal ejection fraction. They have valve thickening and regurgitation, and it's most commonly the mitral valve that is thickened and regurgitant before the aortic valve, both in time of occurrence and in prevalence. Valve stenosis is absent in older infants. And aortic root dilation can be present and include the aortic annulus. So for older infant greater than 6 months of age, the important thing to remember is valve thickening and regurgitation can be present. Here's a picture of the left ventricle showing a very thick mitral valve with the arrow pointing to it. And you can see on the right-hand panel the mitral valve regurgitation, which is now greater than it was in the newborn picture that I showed you on the previous slide. You can see the wideness of the sparkly jet beginning at the mitral valve and extending all the way back up the left atrial wall. You can see, however, that if you looked at the aorta, which is the bottom left-hand panel, there's normal aortic flow in this 1-year-old with untreated MPS. There's no turbulence being shown by the sparkly pattern, and the pure blue signal showing blood flow away from the transducer. What about cardiac findings in children and adolescents with MPS? Again, it's a little bit different. There's normal systolic function, ejection fraction, most always greater than 50%. Valve thickening and regurgitation are often present, and now you're getting both valves, mitral and the aortic. And in older children and adolescents, you start to develop valve stenosis. It's present and it can be progressive. It can affect both the mitral and the aortic valves. And again, aortic root dilation can be a background finding. So here we have the table again that shows you that valve thickening, regurgitation, and stenosis can be present. So we looked at valve regurgitation before. Here's that sparkly signal originating at the mitral valve annulus, and you can see the broad jet going back into the left atrium. Mitral regurgitation is oftentimes classified by the width of the jet at the mitral valve and how far it extends back into the left atrium. But now, as an adult, you can see mitral stenosis. Here's the same picture, same patient, different part of cardiac cycle, showing that there's now turbulence going antegrade across the mitral valve. So there's mitral stenosis in this patient. And here, that aortic outflow image that we looked at previously that was all blue, in this older patient, you can see turbulence starting at the aortic valve. So aortic stenosis can be present in an older patient with MPS. And you can see this develop over time. You can see if you follow patients for many years that mitral regurgitation morphs into mitral stenosis, and aortic stenosis can develop over time. So the cardiac signs, if you put it all together, for an infant, what do you need to look for? You need to look for decreased function. As I mentioned before, you need to look for it because they're going to be undergoing anesthesia. And from personal experience, the one time I didn't see a patient before they underwent anesthesia, I got to see that patient in the operating room when they were under anesthesia because they developed atrial flutter and ejection fraction that was 30%. So they needed to be taken to the intensive care unit, cardioverted, and treated with intravenous inotropes to improve their clinical status. So it's important to make sure that we know in all types of MPS identified by newborn screen that their cardiac function is normal. I can't tell you how often MPS 2 will have decreased function. I don't think that the information is out there just yet. And as we get more patients coming online with MPS 2, that will be an important thing to note. MPS 4 and MPS 6 are going to be things that we need to look for in the future. For the older child, mitral greater than aortic valve regurgitation will presenting. And then for the adolescent and adult, you'll see the development of aortic and mitral stenosis. There are criteria that you can use to determine when is the time to intervene in a patient with mitral or aortic valve stenosis. And the guidelines for intervening need to be thoughtfully employed because there are many other organ systems involved with MPS that need to be taken into account before surgical intervention is considered, primarily the pulmonary status and the fact that if you put a prosthetic valve into a patient with MPS, they will need to have anticoagulation if it's a mechanical valve, and that may present problems if they then need to go on to have orthopedic surgery or CNS surgery. So it has to be a decision that's made understanding what the future may hold for the patient. It's also important to note that bioprosthetic valves, you don't need to use anticoagulation, but they have a limited lifespan of perhaps 10 years. And there is a recent paper from Japan where a bioprosthetic valve was placed in a patient that needed to be replaced early on because they uh, had deposited gag in the bioprosthetic valve. So I think that that is something that is going to become more important as time progresses. So what about the treatment on MPS cardiac findings? Well, it depends upon the finding and the age at treatment. Here's a graph on the left from Simon Jones on 6 patients with MPS 1 who presented with decreased function before bone marrow transplant and were successfully treated with enzyme replacement so that they had normal function by the time of transplant and they had normal function at the last follow-up echo. And this on the left-hand side is the shortening fraction, which is a different one-dimensional measurement of the difference in LV size in diastole and systole. So it's a little bit different than ejection fraction. On the right-hand side is a series of 6 patients that we also saw under 6 months of age who had decreased ejection fraction at their initial exam. And in contrast to Dr. Jones's paper, we gave them enzyme replacement therapy, but in addition to enzyme replacement therapy, before they underwent bone marrow transplant, we couldn't get their ejection fraction up into the normal range, and so we had to give them milrinone as a background medication throughout the entirety of their bone marrow transplant procedure. And once they were engrafted, we weaned the milrinone tube off. And at their latest follow-up, they all had normal ejection fraction. So you may need to do more than just enzyme replacement, but you should know that when you see decreased function, a cardiologist oftentimes thinks of DIG and an ACE inhibitor and Lasix and aldactone, but precision therapy, at least for MPS 1, is enzyme replacement therapy. And so we put a patient on enzyme replacement therapy if they have decreased function, and we follow them along. It may take a couple of weeks, it may take a month, it may take even longer than that to crank it into the normal range, but it most often happens. Cardiac valve disease, on the other hand, does not appear to reverse with either enzyme replacement therapy or bone marrow transplant. This terrible slide, I increased the points that I wanted you to look at. This is a paper from Rosalina Perini, who looked at the different types of of MPS and looked at heart valves of after enzyme replacement therapy. And for all those references that she lists on the right-hand side there, 336 patients with all different types of MPS. There was, at the best, stabilization of valve disease, and more often it was worsening of valve disease over time despite treatment with enzyme replacement therapy. So what's the deal with the valves not responding? So you should know historically that these MPS registries were formed well before newborn screening. The MPS 1 registry was formed back around the year 2000, and the Haas registry soon after. Older children are overrepresented in these registries because there wasn't newborn screening and the patients had to undergo a diagnostic odyssey before they were recognized as having MPS. So for the registries in MPS 2, 4, 6, and 7 and attenuated MPS 1, the average age of children entering the registry is 5 to 10 years of age when valve disease has already been established. Remarkably, for severe MPS 1, the average age of entry into the registry is about a year and a half. Even so, a great percentage of those patients by that time will have valve regurgitation. The other thing to remember is that older children were the ones that were recruited for the enzyme replacement clinical trials. The average age for the clinical trials in MPS 2 and MPS 7 was 5 to 35 years of age. In MPS 1 and MPS 4 was greater than 5 years of age, and in MPS 6 was greater than 7 years of age. So for those reasons, valve disease is already present in children with MPS who are reported after treatment with enzyme replacement. And the real question is it going to make a difference now that we're identifying them by newborn screening? I think that's unanswered so far. So here's just for an example, Chris Kampman recently published a paper about MPS 2 and showed that the average age of starting enzyme in neuronopathic was 8 years, and for non-neuronopathic was 20 years in the Haas registry. And what he found was interesting, and you can see on the right hand is the age at start of enzyme replacement versus no enzyme replacement. And the no enzyme replacement is the right-hand graph. On the y-axis is the cumulative prevalence of moderate to severe valve disease. And that's any valve disease, mitral or aortic. And you can see that starting enzyme didn't decrease the prevalence, but it may have delayed the onset of disease over time. And whether that's going to make a difference in the prevalence and the age of onset once we have newborn screening is a question that we need to answer. So what about bone marrow transplant? Well, there's much less information about bone marrow transplant and valve disease. Dr. Gouffon in Lyon talked about 25 MPS patients who were followed for 7 to 33 years and were transplanted at about 12 months to 6 years of age. And she noted progressive cardiovascular disease in all of the patients. There were 24 patients from Suzuki reported who underwent transplant at 4 to 5 years of age, had a much shorter follow-up, and found a decreased prevalence of heart valve problems compared to untransplanted patients. So maybe what they're seeing is the same thing that Chris Kampman saw, a delay in the onset of valve problems. Again, these were patients that were pretty old when they were transplanted. For MPS 4, there are only 10 patients that I could find that in a series that had that were transplanted. And remarkably, they said that one was improved, but five were unchanged. And so that is the only patient that I found that was actually said to be improved after bone marrow transplant. For MPS 6, again, 17 patients, older age at transplant, follow up for a very short period of time, and the heart was said to be unchanged. This is a very recent paper from 2025. And for MPS 7, I could not find any cardiac follow-up reported after bone marrow transplant. So it seems to be the same story. Older patients transplanted, valve disease unresponsive to transplant. Question is, what's going to happen when you do them younger? So valve disease may be delayed in MPS 2 after transplant. This is the Suzuki paper that I showed you earlier, and you can see that the prevalence after transplant was less versus untransplanted, both for the severe and the attenuated forms of MPS 2. So perhaps, as I mentioned before, what we're seeing is that similarity to the ERT graph of Kampman. So the aortic root dilation is common in MPS. Here you can see a paper on the left-hand side uh, that shows that the aortic root in all types of MPS has a z-score that's greater than 0. You can see that it is most dilated, appears to be most dilated in MPS 4. And you can see that on the right-hand side, the aortic root seems to become more dilated with time in patients. And we know from a couple of studies that the aortic root dimensions are unchanged by either ERT or bone marrow transplant. So the aortic root is behaving similar to aortic valve with therapy. So what we've learned so far is that echo is a reliable way to assess and follow cardiac findings in MPS, that cardiac function is decreased in young infants with MPS 1 and 6. We don't know the story in MPS 2 and 4. Should know that there is a paper from Taiwan specifically talking about MPS 2 cardiac features found by newborn screening, and they reported no cardiac findings in their 6 patients that were studied. And so this is going to be an important thing that we need to study going forward. I would highly recommend that everybody who's identified by newborn screening gets a cardiac evaluation so that we know what we're dealing with and we have the ability to develop a true natural history. We know that valve dysfunction can occur early and it can progress from regurgitation to stenosis over time, and that aortic root dilation is a common background theme. What we don't know is the natural history of cardiac findings from birth onward. So information on the natural history of MPS is incomplete, and this impacts expectation of current therapies. If cardiac valves are affected from birth, can repleting the missing enzyme ever prevent long-term sequelae? What if we do bone marrow transplant for MPS 1 between the ages of 3 and 6 months? Is that going to prevent valve disease? Are there other factors, Dr. Munzer mentioned possibly inflammation, that are important in determining what the outcome will be? Do we need to think about adjunct therapies, anti-inflammatory drugs to prevent the immune system from responding to valve dysfunction? All infants by newborn screen need a cardiac evaluation with echo at diagnosis and regularly thereafter to provide the natural history to create better therapies and as a issue for infants who will likely need anesthesia as part of their treatment plan. Thank you for your attention, and again, thank you for inviting me to speak. So,
With thanks for really an excellent presentation, just showing the challenges, how the disease progresses. I love your slide analogy where you had the facial features change, but the cardiac disease, as you show very nicely, also changes. So one of the questions somebody asked, can you discuss port infections and potential complications needed related to heart valves?
what was the first part of that question, please?
Port infections, Liz, in terms of since a lot of these patients for their enzyme therapy need, peripheral need
Yeah,
access, venous
yeah.
central access, and just maybe discuss the challenges of that briefly.
We've been, we've been very fortunate in that we've, knock on wood, never seen endocarditis uh, from a port infection with an MPS patient. I hope
I should comment, I've seen more than one, unfortunately.
and so maybe you should answer the question then.
No, it's just, I think it's a significant risk factor, in terms of if you have a central line infection, the risk of having a endocarditis, that is the disease settling on the valves, that can be significant. So I think that's just a comment. I think it's important for families who are listening to that. I want to go back to your aortic root dilatation. It's more prevalent than I appreciated. What's the clinical significance, one, of that with time, and what's the mechanism, more importantly? Why does this aortic root dilatation occur? Is it due to aortic valve dysfunction, or if you could just comment on that, I'd greatly appreciate it.
Well, that's very, I didn't actually ask you to ask that question, but thank you.
You're welcome.
In humans, I really don't know the answer, but we have aortic valve dilation as a really prominent part of mouse MPS1, for example. And when you look at the aorta by RNA sequencing in the mouse aorta, they have upregulation of their inflammasome pathways, and they have evidence that they have an immune response happening in their aortas as well. They have all of their white cells, with the exception of B cells, are increased in the murine dilated aorta. And so I think that goes along with things that Brian Bigger has found in the MPS3 mouse brain, where inflammation plays a big role. And he claims that if he gives anti-inflammatory drugs or removes the ability to respond with inflammation, that neurocognitively his mice appear normal by the time they're adults. So whether that is true in humans or not, I don't know, because everybody's still using their aortas. And so I haven't seen anybody histopathologically. I haven't seen aortas in patients like with MPS to answer that question. But it's an interesting thing to think about, because there are guidelines for dilation of the ascending aorta in other diseases. For example, Marfan syndrome, you have a dilated aorta, and it's a progressive disease. There are guidelines for giving Marfan patients beta blocker or losartan to prevent further dilation of the aorta. There are guidelines for participation in sports. There are guidelines for doing surgery on dilated aortas. That information is just not out there for MPS patients. And so it's going to be important to track the natural history of a dilated aorta And it won't be over 5 years, it's going to be over 20, 30 years to see what's going to happen to these patients, especially as they reach adulthood. The thing that I do now is if they have hypertension, I do put them on either losartan or a beta blocker, and more likely I put them on losartan. And if they're really dilated, I put them on losartan as well. I don't know if that's the right answer, but that's the world we live in right now.
That was one of the questions somebody else asked is, are there treatments to delay the aortic root dilation? Do you do anything with that? I mean, to me, you talk about just sort of right near the aortic valve, but I'm not aware of significant descending aortic root dilatation that we see in Marfan's. Have you seen that at all or aware of that
In MPS?
in MPS?
Yes, you see dilation, you see the water bodily looking aorta in some patients with MPS. And in the literature, the one patient who had their aortic root replaced was actually an MPS 2 patient, and it was done because of the dilated aortic root interfered with respiratory and airway function. That's the only one that I've found that's had a surgical repair. Um,
Okay. So another question is, as you alluded to this cardiomyopathy that occurs in the severe MPS 1 or HEROR patients, you said it's any idea percentage, how many patients with HEROR syndrome will present at 2 or 3 months of age with significant cardiac dysfunction in your experience?
about 25 to 30% of them will uh, have decreased cardiac function, and it can vary in severity. The worst one that we've had is someone who showed up with an ejection fraction of 28% as a newborn and uh, got somewhat better on enzyme replacement therapy, but didn't normalize their cardiac function. And that was one of the first ones that we put on milrinone as a background med during bone marrow transplantation. It seemed to work out fairly well. Just tell the transplanters, just put it on and don't think about it anymore until they're engrafted.
No. Any idea the mechanism of that cardiomyopathy? It's not really valvular disease, as we see, as you alluded to later on. We normally don't see myocardial involvement, but in this case, it almost has to be, I presume. And that certainly enzyme does make it better, as you showed very nicely. Sometimes within a few weeks, sometimes longer. Any idea the mechanism?
Boy, I really don't have an idea of the mechanism. You just wonder what has gone on in the transition from being a fetus to being a newborn. That and maybe we need to look at fetal cardiac ultrasounds. Maybe it's going on as a fetus. I don't know the answer to that either.
Yeah, we certainly appreciate there's fetal involvement, and I don't think I've been aware of any fetal echoes on a prenatal diagnosed MPS 1 patient, but maybe in time that should be into, because that's certainly a risk factor for how
Right.
well they do. And it sounds like you would recommend treating the cardiomyopathy prior to transplantation. Is that correct?
Well, we have guidelines that they have to have, and I don't know where this came from, an ejection fraction of 40% or greater to qualify for bone marrow transplant. 40% is not normal, 50% is normal. So I always aim for 50% as the function because there are possibilities there'll be hypertension after transplant, there may be sepsis, there may be any number of complications, and you need a little leeway to deal with those things. And so an ejection fraction that's normal is better, in my opinion.
I think we'd all agree with that. Liz, thank you for a great presentation.